Good evening, everybody. Today we have a new lecture presented by Dr. Omar regarding the emergencies in oncology patients. After the session, we will have the feedback form. Please don't forget to fill it and return it back to us. And now we will have the lecture with Dr. Omar. Yes. Dr. Ahmed, please start.
Thank you very much for that. Good evening, everyone. My name is Omar Elboraey. I'm one of the internal medicine trainees year 1, Health Education England Northwest. Today I'm going to talk to you about some emergencies in oncology patients. And of course, there's like a very big number of oncological emergencies. I'll try to cover few of them today, and I will also try to help you to find yourself the way and to find the guidelines how to deal with this kind of patients, especially on calls, on night shifts when you have lesser level of support with you, unless you stabilize until you stabilize the patient, and the patient will get seen in the next day by oncology team. Is it okay? So I'll start by sharing my screen now. And one second, I've got some issues. Can you see my screen?
Yes.
Okay. Can you see it now?
Yes, we can see it.
Okay,
you can proceed.
So yeah, today we're going to talk about some oncological emergencies. There are a lot of them, and we're just trying today to discuss few of them. I would really appreciate if you can engage with me, and we can make the two-way conversation, and you tell me what your thoughts and how would you manage these patients. I picked today two of the most common emergencies in oncology patients, but I will also show you how to find the guidelines and what to do for the rest of the patients. And maybe we can do further lectures about the rest of the oncological emergencies. Maybe we can make it a series of them. So our ILOs for tonight, by the end of this session, I want the attendance to be able to access the relevant guidelines for oncological emergencies and able to be confidently able to identify and stabilize the patients with neutropenic sepsis, and also able to identify and start the initial management of patients presenting with acute diarrhea, again, oncology patients. So just a quick background, cancer is not something maybe it's bigger than you think. It's not something, it's not few cases in the UK. Actually, in the UK, between 2016 and 2018, there are almost 500 new patients with cancer diagnosed, and also mortality is a little bit high. So we've got between 2017 and 2019, almost 170,000 patients died from cancer. But because here in the UK, we've got proper chemotherapy, early surveillance and identification of cancers, we've got good guidelines in terms of treatment and dealing with complications. So 50% of patients who were diagnosed with cancers, they managed to survive 14 years or more. Yeah, this was in England, Wales, between 2010 and 2011. Okay, so the first thing, I'm going to introduce you the UK Oncological Nursing Society guidelines. It's very, very specific, very detailed, and very comprehensive for you. This kind of guidelines will help you. And during your on-calls, during your night shifts, when you've got few support around yourself, you may be in the clerking shift or even in the ICU or whatever, you got a patient who's coming with severe diarrhea, whatever the complication, diarrhea, neutropenic sepsis. So and you don't know what to do, your registrar most of the time will have like more information that you have. So here I'm just using Google here. You can use Google UK ONS guidelines. You're going to go for the first link here. Make sure it's the PDF one. It will come for you. It will open a PDF which starts like this: UK Oncology Initial Management Guidelines. And then you've got a very comprehensive index. So you've got most of the oncological emergencies. You can just click on any of them and it will show you a very detailed guidance for how to deal with these patients. Okay. Why I'm discussing it is here with you. I think there's a missing slide for that. Sorry. Why am I discussing that? Because I had a few occasions when I was in the clerking night team. Basically, the night team in the medical on-call will be like consisting of maybe 4 or 5 doctors in the maximum. Some of them will be covering the wards. Some of them will be doing the clerking. So you get patients presenting to the ED, coming with neutropenic sepsis, fever, signs of infection, and you find like you got very low white cell count, or even before getting this, the white cell count. We'll discuss that as well. You got other patient coming with acute severe diarrhea, maybe like 10 motions per day. Patients look very dehydrated because they are oncology patients. I know it's a very quite specific areas, so it needs proper practice and management, because you don't know what to give in chemotherapy patients, what to give in immunotherapy patients. And most of us maybe were not exposed to this in proper exposure that give you the confidence to deal with these emergencies. However, what you need to do actually in your on-call or in your ward cover is just to stabilize the patient and start the proper initial management. So you take the first step, you start the initial investigation, you start the proper resuscitation, then the oncology team will identify the patient the next day and will take the management over from you. So you just need to do the right things and the right time. Stop the patient's deterioration, make sure that you don't make any complications, then you're gonna take it from there. So this guideline is basically directed towards who are not specialized in oncology, just to teach them, to support them, how to support these patients, how to stabilize these patients, start the initial management, then they're gonna take it from there. Okay. So I'm going to talk here about neutropenic sepsis, and I don't want to just to be talking there on my own. So I turned off my screen, and I want any one of you just to discuss how would you manage a patient with neutropenic sepsis. How do you suspect a patient with neutropenic sepsis, and what would you do? Like if you're on your night shift, what's your thoughts about neutropenic sepsis, and what would you do? Any thoughts? Yeah, go on, Martin.
Yeah, I think you will have the red flags of sepsis and an expected source of infection. Plus, the neutrophil count should be, I think, less than 500, if I'm not wrong.
Yeah, that's right.
This is a definition of neutropenic sepsis.
Mm-hmm. Anyone else got any thoughts about what would you do if you got a patient with this signs Mohsen mentioned? What would you do for that? Okay, let's go through it again. So I'm going to share my screen again. Yes, so as Mohsen said, we're going to, okay, first of all, just a background. Patients with, okay, patients who received recently or are currently receiving systemic anti-cancer therapy, or have previous history of hematological malignancies or myelosuppressions or bone marrow failure for any reason, have got the potential risk, got increased risk of neutropenic sepsis. Of course, neutropenia. Neutropenia means just like generally low white cell count, and yeah, and of course, because they got low immune system, they will develop sepsis easier than other population. Just a quick overview of the pathophysiology. I'm not going to explain it in details, but you're going to explain it in very simple terms, as one of the hematologists explained it to me, that infection of one of the causes that can cause bone marrow suppression. So if the patient has already got bone marrow suppression because of chemotherapy or because of infiltration of bone marrow for any reason, you are at risk of getting this worse. And when it gets worse, because there's no immune system already in the first place, so this is how they develop the sepsis. So it's called neutropenic sepsis. Suspicion, yes, as Mohsen said. So you need to have very low threshold, very high levels of suspicion for neutropenic sepsis. You need to pick it up. How to pick it up? You get a patient with, again, a history of cancers on chemotherapy, history of bone marrow suppression, bone marrow transplant, on any kind of immunosuppressant treatment. Someone coming with signs and symptoms of infection, you might identify septic focus, you might not. But the patient will be generally tired, feverish, all the investigations, all the symptoms for infection. Then some of them may present with some already investigations arranged by the GB, arranged by the oncology team as outpatient. Maybe the investigations already be done in the ED. Some of them may have not got the investigations yet. The rule here, if you got suspicion of neutropenic sepsis, you need to take bloods and start antibiotics immediately. You don't need to wait for the full blood count results. You can start the first dose of the antibiotics, awaiting the further results. But don't delay delivering treatment for these patients just because you're waiting for the results of your investigations. And the rule here say like door to needle time shouldn't be more than an hour. So in 1 hour, patient presenting to front door of INE, I know this is a guideline rule, and it never happens in the NHS now. The patient can wait in the corridors for 12 hours. But the ideal rule is needle to time, door to needle time should be less than 1 hour. So our approach here, so you identified this patient and you suspected neutropenic sepsis, and then now what should you do? You've started already the antibiotics, and we're going to speak about the antibiotics later. Most of the time the antibiotics is according to the trust guidelines, different from a trust to a trust, but just as a general rule of thumb, you start tazocin, then you change your antibiotics later according to the cultures. So you start as any approach for any other patient. You start by taking proper history, try to identify the patient's symptoms, try to correlate it with any potential source of infection and sepsis. Then using the score will be very important here, because you're going to stabilize the baseline or the initial using score. You're going to monitor that later. You start your normal A to E approach again. Make sure the airway, breathing, circulation, disability, and exposure, and you treat according while you're going through them, and you try to identify your septic focus. Start immediate resuscitation, so whatever it's needed. So if it's chest infection, the patient requires oxygen, you might give him some supplemental oxygen. IV fluids are important, and we know all of this stuff. Then investigations. So this kind of patient, you need to do detailed investigations a little bit. So rather than more like after the routine bloods you're going to take for blood count, CRB, UNEs, LFTs, you need also to have a look on the magnesium. You need to have a look on the bone profile, including the calcium and phosphate. Basically, you're just monitoring all the electrolytes. And in these patients also, you need to get cultures. Blood cultures are very important, and ideally need to be started before giving the first dose of antibiotics. So when the patient comes, you will take the investigation, take the cultures, and start antibiotics immediately. Whole systemic anti-cancer therapy until get reviewed by oncology team. is very most of the oncology patient the oncology team will stop this systemic anti-cancer therapy until the patient gets well, then they can start it again. So you can stop it yourself overnight or over the weekend until you get reviewed by them. Then after that, you will need to initiate the monitoring plan for this patient. I know in ICU, for example, the using score is not doesn't work there, and there's already hourly review of the patient's observations, but this doesn't happen on the ward. So you need to put in your plan that this patient will need daily UNEs and electrolytes for blood count, CRP, and you need the patient at least to have news scores at least 6 hourly to monitor the patient's progression. Then further investigations will need to be arranged as well. So now, after stabilizing the patient, after doing your A to E approach, you might have identified your septic focus, you started antibiotics, you're taking your cultures, you started the proper resuscitation, you hold the sac. So patient might need further investigations to identify the potential source of infection. So for this patient, you might need some swabs, like if the patient got any wounds, wound swab, throat swabs. There's something called rapid GI panel, which is a rectal swab. It can find loads of agents, especially this thing will be helpful in diarrhea. A stool sample, urine culture, and of course, if the patient, many patients got big lines or mid lines. If the patient got a central line, you need a culture from the central line and a peripheral culture. So you need to get culture from both sides, and to see, I think, to examine the site of the line carefully for any signs of infection or cellulitis or line infection. Okay, and yeah, that's it for the neutropenic sepsis patients. Has anyone got any questions?
Yes, I have a question here.
Yeah.
Yeah, Dr. Mohsen first. Okay, go on. You are muted, Dr. Mohsen. You're still mute.
You're still mute. Yeah.
Okay, sorry.
Yeah.
Thanks, Ahmed. Thanks, Omar. Just a comment about the line-related sepsis in general, not specifically for neutropenic patients. It's like a common sense that everybody will look at the site of the line to diagnose line-related infection. Just bear in mind, the site infection is cellulitis, but if it's absent, it doesn't exclude line-related sepsis, because the line is, going towards a central or a peripheral vein, and there might be colonization at the tip of the line, but not causing cellulitis at the site of infection. So in this case, you'll have to take paired cultures and depend on them before easily examining the site of insertion and excluding line-related sepsis. So it's just one of the comments which we face commonly in ICU.
Yeah, I agree with that. I think, that was discussed with one of the microbiology consultants. Yeah, the paired cultures, and then if there's any suspicion of line infection, you need to take the whole line out and send the culture for the tip for cultures.
Yeah.
Thank you for adding that.
Sure.
Yeah, Dr. Mahmoud Mustafa.
Yeah, I just had a question about the whole SAC thing. You said it's anti-cancer survey. What does it mean?
Anti-cancer, systemic anti-cancer therapy.
Oh, okay.
The chemotherapy, basically.
Yeah.
How oncology people like to call it.
Yeah. Okay. Thank you.
Lastly, my question, and the fact that this patient is neutropenic, does the patient needs to be isolated so to prevent any chest infection or something like this?
Yes, the patient needs to be isolated in a side room because they are a higher risk of catching an infection from the hospital. So I think the guide, the local protocols, in our trust here, all the patients with neutropenic sepsis or suspected any kind of immunosuppression, they will need to be isolated in the site room.
Seems to be logic, yeah. Yeah, okay. Thank you.
Regarding the SACT thing, I think SACT, systemic anti-cancer therapy, because it's a broader term to cover chemotherapy and immunotherapy and the other biological agents. That's why they put in the term SACT. Okay, and I'm just before we go, again, I'm going to just quickly show you the guidelines for it. I'll show you how helpful is it and how it takes you with from a step to step before we move to the next topic. Okay. So this is a guideline again. If you click, this is a guideline I showed to you. If you click here on neutropenic sepsis, it will show you everything. So it will show you the antibiotics, what to give, and how to rapidly resuscitate the patient, and what to do in day 1, day 2. But you don't need to do that. You just like you do the first one, the initial management, and oncology team will take care of the patient later. Okay. So next one is we're going to speak about acute diarrhea. Again, patients presenting with acute diarrhea in oncology patients presenting with acute diarrhea. Would you please discuss or express your thoughts about that? What do you think might be the cause? What might not be the cause, and what would you do about that? Anyone got any? They can come to ICU as well because they can be hypotensive, very dehydrated.
Yes,
Yeah.
Dr. Mohsen has a question.
Yeah, I think the first one would be infective diarrhea. As you said, they are prone to infection, immunocompromised. I'm not sure if it can be a side effect of the chemotherapy itself.
It can be, yeah.
Might be related to the cancer itself as well.
Yes.
Maybe electrolyte imbalance as well.
Yeah, most common complication. Anything else? Yeah. Can be, yeah, I think that's it, and can be one of the side effects of the chemotherapy. Immunotherapy can cause colitis, and it can be patients, hematology patients, as they got transplant, can be graft versus host disease. Okay, so let's go through that and see. You can see my screen now, can you? One second. Okay, so acute diarrhea. There's some detailed classification of acute diarrhea in the guideline, but I think the approach would be similar anyway. So if you get a patient admitted with acute diarrhea, you need again to take the history from the patient. You need to assess the patient with the News score. News score just help you to see how severely ill is the patient. A2E approach, and you resuscitate accordingly. Again, you need to arrange some investigations, and here, besides the routine bloods, you need to focus on the electrolyte imbalance. So UNAs, make sure that you get the magnesium, get bone profile, and phosphates. If the patient got any abdominal pain, you need to get an abdominal X-ray. Stool culture is essential here, and GI panel. GI panel is just basically a swab that can test PCR for multiple organisms, including protozoa, some viruses, and some bacterial causes of stool. The differential diagnosis in patients coming with diarrhea in oncology, it's quite wide. I just picked a few of them here. So graft versus host disease is one of the common ones in hematology patients. Side effects of systemic anti-cancer therapy. Side effect of immunotherapy, again, as we said, colitis, infection, as Mohsen said, radiotherapy, and any radiotherapy directed towards the abdominopelvic area can cause diarrhea. It can be constipation with overflow diarrhea as well. So again, we just need to initiate the initial management. We need to stabilize the patient. Then the hematology team would take care of it. Will take over the care. So of course we start with IV fluid resuscitation, electrolyte correction. Of course you hold again the systemic anti-cancer therapy and waiting for the oncology review. In most of the cases, the oncology team, if the patient looks unwell, you just stop the chemotherapy. You can defer the cycle for 1 or 2 weeks until the patient recovers, then they can restart it. You need here, in the guidelines, they mentioned that you need to consider the infective cause, but you don't need to assume that it's only infective cause. So just consider cause as infection, okay? And if you think it's an infection cause, if you suspect C. diff, you can start empirical antibiotic for that. That would be the oral vancomycin. Before you get the results of the stool culture or before you get results of your investigation. So you can start treatment empirically. In these patients, you need to review the patient's medication. This patient is someone who's hypotensive, dehydrated, most probably will develop an AKI. Imagine someone got diarrhea like 10 motions per day or more. So ideally, we need here to review the patient, all the patient's medications, hold anything that can cause hypotension like NSAIDs or calcium channel blockers. Sorry, ACE inhibitors and calcium channel blockers. NSAIDs can cause NSAIDs here can cause an AKI. So if the patient is already in AKI, hold the NSAIDs as well. And what else? Yeah. Consider antidiarrheal medication. So if you manage to exclude the infective cause, so if you suspect that this patient, for example, has got immunotherapy, and most probably the diagnosis here will be immune therapy related colitis with diarrhea as a complication. So you can start loperamide, and usually start loperamide 4 milligrams, and you can add with PRN loperamide 2 milligrams after every motion until you get that controlled. If it's not controlled, you've got codeine phosphate as a reasonable option as well. If the patient got abdominal pain, you need to get an X-ray first to make sure that there is no kind of obstruction or any abdominal emergencies, and you can give the patient some hyoscine. Consider neutropenic sepsis here as well for your investigations or your clinical suspicion from the past slides. You get suspicion of neutropenic sepsis. Graft versus host disease, only in this case, you won't do much for the patient. You don't even give loperamide. You need to discuss with the hematology on call patients. So make sure that you, if you got a patient who recently received some bone marrow transplant, or if you got any kind of suspicion of graft versus host disease, you don't start antidiarrheal medications, and you need to call the hematology first. And yes, so that's how simple is it. I know you can, thank you for today. I know you can see is not much done, but actually it's one of the topics that for me, myself, and for a lot of my colleagues, medical teams and surgical teams, what happens is when you, can you see me? Yeah. What happens when you see an oncology patient on the ward, or if you got a patient on the ED, someone coming with neutropenic sepsis, someone coming with acute diarrhea, emotion, you panic and you know what to do. But this is how simple it is. In purpose, I made it very simple, and I just showed you the guidelines. You don't need to do much for these patients. On my own calls, it happened to me and it happened to my colleagues. And even when you ask the medical registrar on call, who's like, be the one who knows everything, for me as a junior, or even for other specialties, surgeons will call the medical registrar for everything. It can be quite complicated, and you don't know what to do. Even the medical registrar wouldn't know what to do, but they will guide you for the guidelines. And that's what happens to me on a night shift. Like, I've got a patient with this severe diarrhea. We didn't know what to do. I asked the midreg. She didn't know what to do, but then she told me, like, try these guidelines. And actually, it was very helpful. you don't need to do much for the patient. You're not going to fix everything in one day. You've got already a cancer running there. You've already got the chemotherapy cycles. You just need to stabilize the patient. And what you do, if it's very simple things, but it will do a lot for the patient. And the most important thing now, you see how simple is it for managing neutropenic sepsis and diarrhea, and you can now access the guidelines. So hopefully in future sessions we can discuss more. But if you got any of these patients on your own calls, if you meet any of them on your ward or on your workplace, I think you will be able at least to find the guidelines and help yourself with that. Thank you.
Thank you, Dr. Omar Elboraey. It was a very interesting overview lecture regarding the emergencies and oncology patients. Everybody of us actually at some points will find himself in front of one of these patients. Any questions from my colleagues? Yes, Dr. Mohsen. You're muted again. Yeah, you're muted. Yeah.
So it's probably my mouse. Could you please put the link for the guidelines on chat box or the WhatsApp group?
Actually,
in the group will be better. Yeah.
In the sessions, in the first slides, I didn't want to put a link for you because you might lose the link, but I show it to you here. Like, you just need to write in Google. You can do it later yourself, because I know the link. But some of my colleagues gave me the link for that, but you might lose the link, or you might on your own call just find the link. 1 second. So here I'll show it to you again. You don't need to do much for to find the guidelines. What you actually want to do is you just go to Google. Here I'm writing UK. Just write UK ONS guidelines, and you find the link with the PDF, and that's it.
Yeah, it's easy.
As
yeah.
as it is.
And you can use the PDF offline, isn't it?
Yes, you can download the PDF offline.
Excellent.
So you can download it on your computer. You can put it in your phone. But it's as simple as writing UK in ONS guidelines on Google and just open the PDF link.
That's amazing. Thank you so much.
Thank you, Dr. Omar. Any other questions? Okay. Thank you very much, Dr. Omar. Please, my colleagues, don't forget to fill the feedback form, so everybody will get his certificate and the CDP points. Thank you very much, and see you soon in another lecture next week. Thank you.
The feedback form is in the chat now, and
yes,
it's also in the group.
Thank you very much, Dr. Omar. Thank you.
Thank you.
Thank you.
Thanks, Omar.
Bye-bye.
Thanks, Ahmed. Bye.
Thank you. Bye.